Hello everyone, I am Dr. Navin Agrawal, Professor in Department of ENT. So today I will discussing the acute otitis media, which is a very common disease of the middle year, usually seen in the pediatric age group and the younger group, although it can occur in any of the age. So acute otitis is it can be defined as the acute inflammation of the mucoperiosteal layer of the middle ear. Inflammation typically occurs in less than 6. If it is more than 6 weeks, then it cannot be considered as acute otitis media. It will be tagged as chronic suppurative otitis. 60 to 70% of the children, as I already told you, are having the more than one episode before their first early onset, that is less than 6 months, associated with the recurrent AOM and chronic otitis media. With here you can see this is the middle ear, that's my diagram, and this is the tube opening, and this is the middle ear cavity. Okay, next slide. So there can be multiple routes of infection to the middle. First is via the eustachian tube. That is the most common route of infection in the middle ear via the eustachian. The infection travels via lumen of the tube to the lymphatics. That is, eustachian tube is connecting the middle ear with that of the nasopharynx. So sometimes retrograde infection, particularly in children, can lead into the middle ear and the eustachian. Any infection in the nasopharynx or in the nose or in the adenoid can lead it to the middle ear. Then via the external ear to the traumatic ear perfusion. Okay. Third is the blood-borne, which is very uncommon or uncommon route of. Here you can see all the three routes. Is the tympanic membrane via the external acoustic meatus and canal. The infection can travel through the tympanic membrane perforation into this middle ear via the eustachian tube from nasopharynx to the and blood-borne anywhere from any blood vessel. Infection in the common organisms are the Streptococcus, Streptococcus pneumolaticus Streptococcus, hemolytic Streptococcus, Haemophilus influenzae, and Bacillus proteus. Sometimes Bacillus or Staphylococcus is not very much predisposing factors. Now, what are the predisposing factors for a patient to develop otitis media, that is acute otitis media? First is recurrent common cold or respiratory tract infections or viral exanthematous such as measles, diphtheria, whooping cough. So, in viral exanthematous fever as well as the bacterial fevers, infection of the tonsils, adenoids, chronic rhinitis and sinusitis, nasal allergy, tumors of the nasopharynx and cleft palate. Particularly, these tumors of nasopharynx, which usually occurs in the so if a patient is coming to you in adult age group, suppose more than 50 years of age, is coming to you the complaint of pain in the ear with intact tympanic membrane, congested tympanic membrane, or you are suspecting that patient is having the acute otitis media, with or without it, you should look for the nasopharynx for the possibility of. Next slide. This is the eustachian tube and acute otitis media. So you can see in this picture, the eustachian tube is connected via the connecting the layer into the nasopharynx. And in adults, you can easily see that the curvature is more vertical. Here it is broader, wider, and more hollow as compared in the adult is narrower and the more vertical. So the infection can easily go through this horizontal tube into the middle ear via the eustachian tube, but in this case it is less like in adult. So eustachian tube in children, eustachian tube as you can see, eustachian tube is at an angle of 10 degree, while in adults it is an angle of the 45. Isthmus is the narrowest part in the eustachian tube at the junction of the cartilage and bony part, and it is only present in adults. It is not present in the children or pediatric age group, infant. That is why the infection can easily spread into the middle ear to the infectious organism. As you can see, most common infectious organism is Streptococcus pneumoniae. Then Haemophilus influenzae in 20% of cases, Moraxella catarrhalis, other Streptococcus pyogenes, Staphylococcus aureus. Fungal are less common, but still they can infect the middle ear. As these are the most common fungi are the Aspergillus and Candida. Bacterial otitis media from superinfection of virus also possible. Pathophysiology. First is the stage of tubal occlusion, then stage of presuppuration, stage of suppuration, stage of resolution, or now the first stage. First stage, that is the stage of tubal occlusion. It is usually associated with the mucosal hyperemia or because of the viral infection, which only causes the hyperemia, or which can lead to the tube occlusion. And once the eustachian tube is occluded, there will be decrease in temperature, as eustachian tube has two functions. First is to ventilate the middle ear, and another is to drainage of the middle. So both these functions will be hampered if eustachian tube is occluded. So there will be the middle ear is absorbed, so intertympanic pressure will be decreased, and collection of fluid will be there. Okay, so air increases, fluid increases, and tympanic membrane retracts. That is the stage of tubal occlusion, in which you can see the symptoms like deafness, mild deafness, and right, along with the fullness of signs. There will be retraction of the tympanic membrane, loss of cone of light, tuning for test may be showing conductive deafness, mild conductive. On otoscopic examination in tympanic membrane, in stage 1, you can easily see there is tympanic membrane retraction, foreshortening of the angle of malleus, no cone of light, and prominent lateral process of the malleus. That is another sign for the retraction of the tympanic. But here you can see there is no congestion of the next slide. Now, second stage, that is the stage of presuppuration. Presuppuration means there is a fluid formation, but it is not getting infected by the secondary bacterial infection. Only fluid collection is there in the biliary cavity. That is presuppuration. So bacteria starts invading the tympanic cavity. Anemia will be there, inflammatory acids and congested tympanic membrane. Symptoms will be the marked earache, disturbing of nature, deafness and tinnitus, high degree of fever, and restlessness. Signs congested pars sensa, cartwheel appearance of tympanic membrane, tuning for test showing conductive deafness. Here is the stage 2 in which you can see cartwheel appearance of the tympanic membrane because it supply the tympanic membrane is radial in nature. That means it is the vessels are arising from the center and going towards the periphery. That is why if they are hyperemic, that it shows cartwheel appearance and cone of head is lost. Then the stage of operation, in which the pus now frank pus will be there, pus increases, TM is compressed, ischemic definitely because of the compression, tense and bulging out, or there can be necrosis of the tympanic membrane. In this, symptoms will be the excruciating pain of the ear of the ear. Patient will complain of the severe pain in deafness. There can be fever also, vomiting, convulsion, and in after which the patient signs. TM appears red and bulging yellow spot on tympanic membrane, tenderness over mesodentum, X-ray mastoid, clouding of the ear cells. Next slide. These are the signs of the stage 3. Bulging out tympanic membrane. So you can easily see here, bulging out of the tympanic membrane, loss of anatomical landmasses. And here you can see the clouding of the mastoid ear cell. Now the stage of resolution. TM ruptures, pus drains out, and symptoms subside and resolution starts. In which stage you can see a perforation in the tympanic membrane, usually in the inferior quadrant and posterior inferior quadrant because they are the most dependent is areas of the pus comes through the perforation in the inferior quadrant. Mild infection, early antibiotic resolutions, no rupture of the tympanic membrane if you are starting the antibiotics early. Otherwise, there will be perforation. If there is no perforation, earache relief and fever comes. Signs ESC contain blood, rather mucopurulent is small perforation of the tympanic membrane. Complications. There can be certain complications also of the acute otitis media. In this case, you are seeing a child with some problem. What is that? I would like to know by yourself. Complications. If highly virulent organism or low immunity or inadequate treatment leads to the stage of which can be acute meningitis, subperiosteal facial paralysis, labyrinthitis, petrositis, meningitis, or brain. So, will you manage a case of acute otitis? There can be medical management, which is the primary management, or the most commonly practiced management. Medical. You have to give systemic antibiotics, nasal decongestant, systemic as well as topical, H1N2 examinations. It leads to some anti-inflammatory property, analgesics, antipyretic, oral toilet for a discharge. If patient is having a discharge, then oral dry mouth. Hot fermentation for severe earache and in 48 hours. In 48 hours, earache plus fever persist, then change to higher anti. You have to change the anti. TM is bulging, then you have to perform myringotomy. That is the surgical management of acute otitis. Yeah, in you have to create a hole tympanic membrane at the entero-inferior quadrant just to release the pus. And you can send the pus for the culture and distribution. Earache plus fever subsides, then continue the same treatment for 10 to 14. After 3 months, you have to review the patient. No effusion, no further treatment is required. Fusion persists, treat as otitis media with infusion, that is blue ear or serious otitis media, and presence of abscess or pollution masquerade, then do cortical masquerade. Myring. What are the indications? Symptoms are noted by antibiotics, EM bulging significantly, EM perforation is too small, incomplete resolution, or persistent diffusion beyond 12 weeks. These are the indications. Okay. Myringotomy in a case of acute otitis. So this is myringo. What we are doing here, depiction in a diagrammatic form. This is the ESC and tympanicum. This tympanicum is bulging. Here you can see the tympanic membrane is bulging. So in this, you are removing just the outer debris or pus axonometric canal. Then you have to incise the tympanic with the sickle knife or miring it, the inferior quadrant of the tympanic. You have to create a tiny incision, and you will give the message to the pus to drain into the ear via that hole or incision. Okay. So the pressure will be relieved and middle ear will be cleared of the. Now, what are the underlying predisposing factors for acute otitis media? As you can clearly see, there are different mechanisms, there are different diagrams in this, which suggests us that chronic rhinitis, chronic sinusitis, chronic tonsillitis, or chronic adenitis can lead to the acute otitis. You can have the look in this picture for a time, for some. These are the different suggesting different stages of tonsillitis or different uh, grading of the tonsil. It is surgically removed, grade 1, grade 2, grade 3 symptoms. Here, nasal cavity, adenoid, which is over the eustachian tube, causing the blocking of the eustachian. This is the acute otitis media. This is another entity of acute otitis media in which there is no infectious material discharge or pus in the media, but there is only sterile fluid and the intact. That is otitis media with infusion, also known as serous otitis media or glue. Definition. Proper definition is the chronic accumulation with mucus, non-purulent effusion within middle ear. That is the main highlighting point, that middle ear discharge is non-purulent. It is sterile in nature. Then and then only we can tag it as the blue ear or serous otitis media or acute media. Here you can see the normal. Here, these are the otitis media. Is the infected fluid in the middle ear, and infected, if it is infected, then it is considered as the otitis media, and if it is non-purulent sterile, then it can be considered as otitis media with. Okay, no names are already told you: blue ear, psoriasis otitis media, chronic non-purulent otitis. So, pathogenesis. What is the pathogenesis for the formation of otitis media with effusion? Malfunctioning of the eustachian tube. Eustachian tube fails to aerate the middle ear and unable to produce fluid in cases of the adenoids, in cases of tonsillitis, in cases of the chronic rhinitis, sinusitis. Increased secretory activity of middle ear mucosa. There are certain diseases can cause the increased secretory activity of the biopsy of the middle ear mucosa in these cases have confirmed increase in number of mucosa serous secretory etiology. Malfunctioning of the eustachian tube. As I have already told you, we have discussed it earlier, adenoid hypertrophy, chronic rhinitis, sinusitis, chronic tonsillitis, benign and malignant nasopharyngeal tumors, or palatal dip. Then allergy, seasonal or perennial allergy to inhalants or food stuff is common in children. Obstructs eustachian tube due to unresolved otitis media can also lead to the otitis media with effusion and viral infections such as adenovirus, rhinovirus. And in recent times, corona also can cause the otitis media with effusion. Other viruses such as respiratory syncytial virus also can cause the otitis media with effusion because virus is known to cause only the fungi. So clinical. Usually it affects children of the age of 5 to 8 years. Hearing loss is the most common presenting symptom. Sometimes the only complaint. It is insidious in onset and rarely it's spotted. Delayed and defective speech can be there because of the hearing loss. Development of speech is delayed or defect. Mild earache can be there. History of URTI, recurrent URTI can be there. Poor school performance also a sign or a clinical feature of the ear. Now the otoscopy. Tympanic membrane is often dull and opaque with loss of light. It may appear yellow, gray, bluish. Thin leash of blood vessels may be seen along the handle of the membrane or at the peripheral membrane. Tympanic membrane may show varying degree of retraction also. Fluid level and air bubbles may be seen with fluid is thin and membrane is transparent. Now, last mobility of tympanic membrane is transparent. I think it will come mistake. Mobility can be restricted in the otitis media with hearing test. You can go for the hearing test, tuning for test. As you all know, conductive hearing loss will be there. So, drainage will be negative and Weber will be lateralizing to the affected. Audiometry conductive hearing loss, usually of the 20 to 40 decibel, means only mild to moderate, up till moderate. Sometimes associated with the sensory hearing loss due to fluid presenting on the round window membrane. This disappears with the evacuation of the fluid. Impedance audiometry, it is an objective test useful in infants and children. Shows flat curve with a shift to negative side due to image component. That is the B-type curve. B-type. X-ray mastoid clouding of air cells can be there. Now, what is the treatment for the otitis media or medical? Usually, medical treatment is sufficient. Maximum medical management, you have to give the decongestants, topical in the form of nasal or systemic decon, such as topical decongestion, such as thimerosal, nefazolin, xylomethrin. Systemic decongestion, pseudoepidermis, which is now being used very rarely. Anti-allergic measures, antihistaminics, or sometimes steroids, antibiotics. If patient is having the unresolved ASOM or having the recurrent attacks of sinusitis or tonsil, then you can give middle ear aeration and ask the patient to practice Valsalva. Surgical management of the otitis media with and that is myringotomy. An incision is made sometimes made in the tympanic membrane. Fluid is aspirated sometimes. Two incisions are made, as you can see in this diagram, one in the anteroinferior and another in the anterosuperior quadrant, just to aspirate the fluid. If fluid is thick, then you have to make another incision in the anterosuperior quadrant. Now, sometimes you also need a grommet insertion if you think that patient is having the ongoing history or can have the ongoing recurrent otitis media with effusion because of this some other pathology, that is most commonly the adenoids of cleft palate or nasopharyngeal. But then you can go or you should go with the grommet insertion also. In this, you have to make an incision in the enteroinferior quadrant of the tympanic membrane. A J-shaped incision is given. Then you can insert a tympanostomy tube or grommet to communicate the middle ear with that of the external. And it will serve as a purpose of the ventilation as well as the drainage from the middle ear towards the external. It is left in place for weeks or months or till it is spontaneously extruded. Now, tympanotomy or cortical mastorectomy, if it is sometimes required for removal of the local fluid of other associated pathologies such as cholesterol granuloma. Surgical treatment of the positive factors such as appendectomy, tonsillectomy, or some sinus operation. Complications of the otitis media with infusion. Atrophic tympanic membrane and excess of the middle ear, ossicular necrosis, most commonly long process of the incus get necrosed, tympanosclerosis, retraction pocket, and cholesteatoma, cholesterol granuloma. Although this seems that there are many complications, but usually patient recovers very fast and completely. So, but we have to take some time and diagnose it properly to get relief of this symptom. So, thank you.